Welcome everybody to this session on reframing health as an asset, making the economic and social case to invest in healthcare at the HSR UK virtual conference in 2020. And this is research that's been funded by the Health Foundation on the social and economic value of health research program. So today we're going to have three speakers, Padraig Dixon from the University of Bristol, myself and my colleague Simona Rasiuti from Loughborough University, and closing out with Andrew Bryce from the University of Sheffield. So without any further delay, I will bring on our first speaker, Padraig Dixon, who is going to talk about Mendelian randomization and causal effects. Thank you, Padraig.
Thank you very much, Paul. So if we just move briefly on to the next slide, please. So I'm going to talk about some research that was published in March of this year with the support of the Health Foundation. And this research is looking at a new way to measure the causal effect of adiposity, so as measured by body mass index and waist hip ratio on hospital costs. And if we move on to the next slide, please. So the first question is why might we be interested in this question? So we all know obesity is an increasingly prevalent condition. It's a very high impact in terms of mortality and morbidity, and it's also an increasingly long-term condition. And we do have evidence from, for example, trials of surgical interventions such as bariatric surgery, which are effective. But we need long-term evidence to know if the impact of that kind of intervention on healthcare costs is sustained beyond the end of trial follow-up. Likewise, other interventions that aren't subject to randomized evaluation, such as the sugar tax, which has been introduced in the UK, the biggest impact of a tax like that might be on young children whose health has improved many years in the future, and it's very difficult to get randomized evidence of the impact of such an intervention on cost in the future. So if we get next bullet point, please. We only have observational evidence of these types of long-term impact at the moment because we can't simply randomize people to be obese. We can't have trials that are extremely long follow-up. And the evidence, next bullet point, please, from systematic reviews is that observational evidence isn't good enough. It's subject to a lot of biases. So if we go on to the next slide, please. So existing types of analysis suffer from particular form of bias. So if we're interested in the association between BMI and healthcare costs, indicated by the arrow going from BMI to healthcare costs, it's always the case that there are omitted confounding variables that jointly determine both our weight and how much is spent on treatment costs. So that might include, for example, whether we're employed, whether we live in a prosperous area, whether we smoke, and other comorbidities that we might have. So if the next bullet point, please. And the next one. So this directed acyclic graph is showing that the true relationship between healthcare costs is a function of both BMI and these other variables that we may not be able to measure. So in a sense, they're omitted. So the true relationship is this function of both BMI and these other variables. So if, next bullet point, please. If we only estimate a relationship that relates costs to BMI, and the next bullet point, please. What we're doing is we're estimating this association with bias because the true association is a function of both BMI and all of these other variables. And if we neglect these other variables, which generally we do, because we can't control for everything that might influence our exposure, which is BMI and healthcare costs, our outcome, we're creating bias that's a function of the association between these omitted variables and BMI. So if we neglect to include employment status or we neglect to include smoking, we're estimating this association between BMI and healthcare costs with bias, and therefore our comparisons of different types of intervention are unreliable. So on the next slide, we have the solution that we applied in this paper, which is the use of something called Mendelian randomization. And this is the use of common genetic variants. In this case, they're known as SNPs, which is an acronym that stands for single nucleotide polymorphisms. So these are little bits of the genetic codes that arise randomly at conception. And these random variants influence our liability to have higher or lower body mass index. And by virtue of their random allocation at conception, they are independent of all of these confounding variables, such as employment or mental health or where we live, and the other types of health conditions that we have. And therefore, we can use these genetic variants as an instrumental variable. And if we go on to the next slide, if these common genetic variants, the SNPs, fulfill these instrumental variable assumptions, then we can make robust causal inference in a way that's not possible with existing methods. So if the SNPs are related to BMI, and if they're independent of the emitted variables, and if they only influence healthcare costs via their effect on BMI, then we can identify a robust, credible causal effect. And this is a new form of analysis for this question. So the challenging assumption for instrumental variable analysis in this case is the final assumption. So this is the idea that the SNPs only influence healthcare costs via their effect on BMI. In practice, we know that some genetic variants, some SNPs, have influence on multiple traits. This is known as pleiotropy. So I'm going to present some results from empirical models that relax the third assumption that the SNPs only influence healthcare costs via their effect on BMI. Hopefully that'll be clear a little bit later when we move on to the next slide. So we use data from UK Biobank primarily. So this is a very large, high-quality cohort of 500,000 people of middle age and early old age who were recruited between 2006 and 2010. All of these 500,000 people attended research clinics where their weight and height was measured by research staff. So there's no measurement error here. This is measured by nurses. After we made some necessary exclusions for the genetic analysis, we had just over 300,000 individuals, of whom a slight majority were female. And because of the genetic analysis we do, we had to restrict the analysis to people of recent European ancestry. Mean age was just under 57 years, and most people in our sample are a little bit overweight, so their mean BMI is over 27, and about 1/4 of the sample was obese, so that's a BMI of over 30 kilograms per meter squared. So our cost data is inpatient hospital cost in NHS hospitals, and the mean per patient per year cost was just under £500. That's a very skewed distribution, so some people use healthcare costs very heavily, so the median was only £88. And we had just over 6 years of follow-up of inpatient hospital care on which to do our analysis. So if we go to the next slide, we'll see some results. So if we do traditional multivariable regression and we measure the effect of an additional unit of BMI on inpatient hospital costs per year per person, we get an estimate of £13.47. If we do the Mendelian randomization analysis, assuming that all of the assumptions are completely fulfilled, we get an estimate of over £21, which is substantially higher. So that's indicating that if we use instrumental variable models, we're getting a higher estimate of the effect of BMI. But there is evidence that that third assumption is violated, so there is heterogeneity in these estimates. So we need to look at the pleiotropy robust estimate. So if we go to the next slide, we will see the results from estimators which relax that third assumption and allow the genetic variants we use to have an influence on the outcome other than via BMI. And for those methods that are precise, particularly the penalized weighted estimator and the weighted mode estimator, we're again getting higher estimates. So this is telling us that the unbiased estimates are giving a higher impact of BMI on NHS hospital costs. And if we go to the next slide, we can think a little bit about some of the implications for policy and public health of those higher estimates. So the overall big picture message is that if we use these modern methods for estimating these associations without bias, subject to the assumptions of those methods, we're implying a bigger impact of higher BMI on hospital costs. And in turn, that implies that obesity is potentially a bigger problem that we might have believed before. And a consequence of that is that we potentially should be spending more money in the NHS to reduce BMI profiles that are high, so the obese and morbidly obese categories, because those interventions are actually more cost effective than previous estimates would have led us to believe. And that has implications for research prioritization. So we might need more trials and studies in relation to obesity. And of course, any intervention that we've evaluated in the past using existing methods is potentially understating the cost impact on the NHS. So that's the end of my presentation, and I'll leave you with those implications. Thank you.
Thank you, Padraig. If you could move on, please, Hardik, to the next slide. So at this point, we're going to move on to the presentation that myself has been involved in, along with my colleagues Simona Rasuti and Harish Kumar from Loughborough. And we were looking here at health being an asset, and particularly focusing on the impact that that might have on individual family, social and economic life. Next slide, please, Hodip. So the structure of the presentation is as follows: a brief review of the social determinants of health and what our study is trying to add to that, and particularly focusing on some of the priorities that the Health Foundation identified, that health, rather than being an outcome of social and economic conditions, can also be a driver of those conditions. We'll then briefly outline the study, indicate some results and offer some initial conclusions. Next slide, please. If you do a couple of clicks for me, Hardy, thanks. So the starting point of our research was really picking up on issues from the Marmot report that identified essentially two main issues. First of all, that there are health inequities in society, and secondly, that there's a social gradient to those. And so we know that social and economic disadvantage can actually drive disparities in health. Next slide, please. But also, and if you do a couple of clicks for me, thanks, Hardy, there's an important view that, in fact, health as an asset could actually be something that drives those outcomes rather than just is the driver of them. And particularly if we think about health as being something that's not just about tackling illness, but it's also about promoting wider flourishing in society, then we need to try to explore whether or not health has causal impacts on people's lives. Next slide, please. And that's what drives us on in terms of this research. So we're responding directly to the Health Foundation's call to have a look at how someone's personal, physical or mental health can have an impact on their economic and social lives, both the medium and the long term. Next slide, please. And at this point, I will hand over to my colleague, Simona.
Hardip, a few clicks, please. So we use harmonized British household panel in this study. BHPS commenced in 1991-92, and it reviewed about 10,000 individuals each year, and then it was subsumed into Understanding Society dataset in 2009-10, which surveyed approximately 40,000 individuals per wave. So it allows then the coverage of individuals from 1991 to 2015. Next slide, please. Couple more clicks, please. So we are looking into three broad outcomes. So the first one is satisfaction with a partner. And this outcome does not only look into marital status, which we control for, but also the quality of the relationship. The second outcome that we'll look at is financial situation. And this outcome is a broad outcome that takes into account individuals' capacity to participate in economic, social, and cultural activities, not just their income and employment prospects, which we also control for. This outcome takes into account the fear of experiencing financial hardship, regardless of current stated economic circumstances. And final outcome is a measure of structural social capital, which is measured by the number of memberships of organizations. So the treatment are two variables, which is, first one is general individual subjective health that takes into account physical health measure. And then we have GHQ-12, which is normally a measure of mental health. Next slide, please. A couple more clicks. So we know in the literature, there is a lot of research done on the socioeconomic outcomes, the effects of socioeconomic outcomes on health. However, the effects on health, also the causal effects on health on socioeconomic outcomes are still underexplored. Next slide, please. A couple more clicks, please. So as a result, we employ instrumental variable analysis to investigate how physical and mental health affect the three broad outcomes. And we do take into account also confounders such as income, work status, education, number of children, marital status, as well as an observed time invariant effects. Over to you, Paul.
Thank you. If you could move to the next slide, please, Hardy. So these three graphs, if you can just do one more click for me, Hardy, illustrate the main findings that we've got. So as you can identify here, each of these plots the percentage of respondents against the outcome variable. and breaks that down to one aspect of the measurement of health. And what you can see there, for example, in the top left-hand diagram, is that if you look at people who are more healthy in terms of their mental health, that you see that there's a greater chance that they're happy or satisfied with their relationship. Likewise, if you look at the financial situation, that you see people who've got excellent health, and that's based on the general health measure, that they are in fact more likely to express the fact that they're living comfortably. And likewise, in the bottom diagram, this is looking at the number of organizational memberships that people have, which measures the extent and structural capacity for people to experience social capital. You can see that there's a switch point around the one membership of an organization that occurs, which shows that the very poor after that, in terms of health, participate less than those that are showing higher health. So that's a sort of qualitative introduction to what we've done. And just to give you some idea of what the kind of quantitative results are, Hod, if you could go to the next slide and just do a couple of clicks for me, please. And one more, thank you. What we've got here are just to give us some idea of the relative effect sizes of the results that we've got. And to indicate those, these are elasticity measures, that is proportionate responses in the outcomes to the health conditions, and just calculated at their mean values to give you some idea of the main effects. And what you can see there is that in terms of satisfaction with relationships, there's a small negative association with being male. And interestingly, this is the only causal effect that we could find, but it does suggest there's a potential sort of vicious circle here for males, in that if they experience a mental illness, then the satisfaction with the relationship falls. But we know from the associational analysis too, that satisfaction with relationships is also a component of people's mental health. So perhaps unlike females, there's a kind of a vicious circle here with relationships. In terms of the other two measures, the two biggest outcomes that we identify is that in terms of social capital, it's the general health measure that seems to matter, more so for males, which suggests more about their social engagement relative to females in the external world outside of the household. But also, it's not so relevant or significant for the mental illness. So there's something here about physical capabilities that's driving that result. And when we come to look at the financial situation case, we can see that here, this feeling about whether you can cope financially with the challenges that you've got, independently of your income and your work status, does seem to be driven a lot by people's mental illness states. So if you do another couple of clicks, please, Hardip. We also tried to explore these conditions over time, and we're able to try and do that through looking at interaction effects. And what we did find is that as you look at these effects across age cohorts, then there are changes. And particularly with the social capital results, we identified that the effects, the positive effects, actually diminish, which suggests that there's some reduction in capability to engage with the external world outside of the home. And in terms of financial situation, there was a kind of decrease of the impact of the mental illness on the outcome, which suggests that possibly older people who have greater access to assets as they age can actually insulate themselves a little bit against some of this pressure that might come from mental illness and concern about your financial situation. One of the other things that we also did in the research was try to link particular conditions to the health measures that we've used, that's both general health and GHQ-12, and we found that certain of those conditions were very important, and that they're sort of listed there for you to see. So particularly the things that you might expect: anxiety, depression, things connected with drugs and alcohol, and of course, heart disease and sort of cancer. Next slide, please, Hodip. And if you just do a couple of clicks. So I think we've managed to demonstrate a couple of important things from this research. And the first is around causal insight. And I think what we've been able to show from the analysis is, while there is that strong evidence that links social determinants of health, whereby social conditions drive health, there's clearly evidence here that health is also something that can drive those social aspects, and they can transverse both the individual, the personal relationship, the economic sphere, and also the social sphere. And I think what's more important from this is you can see that interventions that might target a particular aspect of health will have spillovers to other areas. So where we think that further research is required is to explore something about this heterogeneity and some spillovers, and particularly links with respect to aging and social capital, how best to harness people's opportunities to engage in social capital in connection with aging, and of course with respect to younger people and their mental illness and the extra pressures that a lack of access to financial assets might have. So these are the sort of factors that we think are important for further research. And that's our presentation finished. Thank you, Hardip. Okay, so I'll now move us on to our third speaker today, which is Mark Bryan. Sorry, it's Andrew, I think. And they're going to look at health as an asset and the effect of physical and mental health on sickness absence. So over to you, speaker.
Okay, thank you, Paul. In this presentation, I'm going to continue the theme of health being an asset. Obviously, health is important as an outcome in itself, but it also is an asset that can be used in other aspects of life. And our team has particularly looked at the issue of the labour market. How does your health conditions affect your labour market outcomes? This particular paper is looking at sickness absence, and this is a joint paper with Mark Bryan and Jennifer Roberts. We're all at the University of Sheffield, and like all of the presentations today, we're funded by the Health Foundation, the Social and Economic Value of Health program. So if you'd like to move to the next slide, please. So I'll first of all talk about sickness absence in the UK, give a bit of a context to the issue, and then think about to what extent is this a problem. Then I'll introduce our research questions, show you some results, and finally conclude. Next slide, please. So we can see from this chart that sickness absence has been declining over time. At the last available date in 2017, we see that each worker in the UK missed about 4 days of work per year due to sickness absence. This is reduced from 7 days per year in 1993. But the important thing to note is that this varies substantially according to whether or not you have a long-term health condition. So a person with a long-term health condition will, on average, miss about 3.9% of their working hours due to sickness absence, whereas those who don't have a long-term health condition, that effect is only 1.2%. And so in this paper, we kind of unpack this a little bit more and try to see the extent to which long-term health conditions are actually a causal predictor of sickness absence. Next slide, please. So it's estimated that sickness absence costs business £522 for every employee every year. So it has a huge economic and business cost. And it's not only businesses that foot the bill. Taxpayers also will end up paying due to statutory sick pay, which is what the government pays employers to help them to compensate people who are off work due to sickness. And the cost also extends to the workers themselves due to loss of earnings, inhibited career progression, and also missing out on the wider benefits of work such as health and well-being. So this is a very important issue for many stakeholders. Next slide, please. So our research questions, first of all, primarily is to investigate to what extent is the relationship between health and absenteeism causal? And also, does it matter what type of health condition you have in terms of how this is predictive of absenteeism? And in particular, is there a difference between physical and mental health? And indeed, we find that there are substantial differences, which I will come to later. And does the risk of absenteeism due to health problems depend on the type of work that you do? So to answer these questions, we look at the UK labour force survey. So we have about nearly 1 million observations over 10 years between 2009 and 2018. these are employed people aged between 21 and 55. So on the next slide, we will see that we can just have a little look at the data in a bit more detail. So the LFS asks people about the week just gone. So this is like a snapshot into people's lives. And we find out whether or not the individual responding to the questionnaire has worked fewer hours in the reference week relative to the number of hours that they normally work, and whether this reduction in hours has been due to sickness absence. And so we define sickness absence in two ways. First of all, we identify anybody that's had any absence in this given week. And this is shown by the blue bar here. So we can see that people with no chronic health problem, only about 1%, just over 1% of them have any sickness absence. But this increases to over 2.5% for people with health problems. We also look at people who did no work in the reference week due to sickness absence. They were off the entire week, and this is like a proxy for longer term absence, perhaps more serious sickness absence. And this is shown by the orange bar. And as you would expect, this is much lower. So I think only about 0.2% of people with no chronic health problems are actually off for the entire week. But this rises to still less than 1% for people with chronic health problems. And you can see here that the nature of the health condition is related to the probability of sickness absence. Those with progressive illness are the most likely to be absent, both short-term and long-term. And the second biggest group is depression, those with depression, bad nerves, or anxiety, or we might call them common mental health disorders. And note that these are people with health problems, with chronic health problems, those that last 12 months or more, or expected to last 12 months or more. Okay, next slide, please. So we've seen the associations, but what we're really interested in is whether this is causal. So it's perhaps no surprise so far that people with chronic health conditions are more likely to be absent of work due to sickness. But to what extent is this causal? There may be many other confounders, personal characteristics and work characteristics, that influence the likelihood that a person might be off work sick. So to try and control for these confounding influences, we put everything together into a pooled probit analysis, and estimate the average marginal effects of having a given health problem on probability of absence. And that's what this graph here shows. And we can see right at the top that having a health problem is significantly predictive of having a sickness absence. So it extends your probability of having any sickness absence by nearly 1.5 percentage points, and by about 0.4 percentage points for being absent all week. And we can see here that the effect of a mental health problem is much higher than the effect of a physical health problem, but both are still positive and significant predictors of sickness absence. But you can see that there are a few particular conditions, namely problems with arms or hands, which actually, once you control for confounders, people with these particular disabilities are no more likely to have absence from work than anybody else. These confounders that we're controlling for might not be all the confounding influence on the outcome of interest. So what we do also is to exploit the panel nature of the LFS. So people are not interviewed by the LFS just once. They actually stay in the sample for 5 quarters, and so we can actually track their change over time, quarter by quarter. And many of them actually do change their health status, even though this is long-term health status. And of course, they will change their absence behavior as well. So if we go into the next slide, we can see the results of a correlated random effects probit, which controls for this within-person variation, these unobservable characteristics which might be causing people to be more likely to both have a health condition and also be absent from work. So these might include family characteristics. They might include some unobserved aspects of their work, the work stress, for example, which might make them more likely to actually take time off. And actually, by controlling for these unobserved characteristics, the effects are reduced significantly. In fact, interestingly, when you just look at the longer term sickness absence all week, having any health problem, this is the orange bar at the very top, is not at all predictive of sickness absence. So if you go from one quarter having no health problems to the next quarter having some kind of health problem, actually this is not predictive of increasing your sickness absence, but it is predictive of increasing your short-term absence, as shown by the blue line. We can also see that physical health is predictive only of any absence, but not of absence all week. And yet mental health problems are predictive of both. But even for any absence, if you have the onset of a mental health problem, you are 3 times more likely to have sickness absence than if you were to contract a physical health problem. So the difference between the two is significant. And if you have a mental health problem, you're also more likely to be absent all week, although that's not the case for having a physical health problem. And if you look down at the bottom, you find that depression or anxiety is predictive of both long-term and short-term absence, whereas most physical conditions, with the exception of progressive illness and to some extent stomach, liver, kidney problems, are not predictive of sickness absence. So if we go to the next slide, a final thing that we did was to explore whether there's any interaction between health and different work characteristics. So does it matter what sort of job you're in as to whether or not your health actually predicts sickness absence? Again, this is in the CRE probit model, as we had in the last slide. And we do see a few interesting results here in relation to long-term absence. We see that actually if you work in a large firm, 50 to 499 employees or 500 or more employees, having a mental health problem or having the onset of a mental health problem does result in an increase in your sickness absence. But if you work in a smaller organization, then it doesn't. And this is interesting. It's not clear here whether this is a good or a bad outcome. This could mean that smaller organizations are more conducive to people with mental health problems, and so having a mental health problem is not a particular risk factor in increasing your absenteeism. But it could also mean that people who do have mental health problems and perhaps need to take sickness absence are not doing so due to a phenomenon called presenteeism. And whether presenteeism is more prevalent in small firms would be an interesting area for further research. And on the left-hand side, we can also see that there's a difference between the private sector and the public sector, in the sense that having a health problem is predictive of absence in the public sector, but not in the private sector. And again, does this mean that the private sector is more effective at helping people manage their health problem, or is it that people are going to work despite being sick perhaps with a mental health problem in the private sector when they're not doing so in the public sector. And we also see a variation by gender as well. So women who have the onset of a health problem are likely to increase their sickness absence, their long-term sickness absence, but men are not. Next slide, please. And finally, to conclude, so we see that chronic health conditions are significantly associated with both short and longer term sickness absence. But actually, when we look at the change in health over time, we see that physical health only affects short-term absence, whereas a change in mental health affects both short and longer term absence, and the effect is much higher than for physical health. And an important point here, this shows that investment in health, particularly mental health, will bring about benefits for business and the economy due to reduced sickness absence. So, although other factors do affect whether or not a person with mental health is more likely to be sickness absent, we do show that actually having the onset of a mental health condition is a risk factor for sickness absence, controlling for everything else. So investment in health will have an important part to play. And finally, we can see that the risk of a health shock leading to sickness absence is higher in some workplaces than others, particularly larger workplaces and the public sector. And the question remains as to, is this a good or bad thing? Okay, thank you.
Thank you very much, Andy. I wonder if we could just move on now to a discussion. So at this point, having had the three presentations, I would just like to invite back the speakers to offer some of the main insights from their research, and also to suggest, perhaps even restate, some of the opportunities for future research to further inform the insights that we have. So at this stage, I will just invite back Padraig to address those issues. Thank you.
Thank you, Paul. Yeah, so I think the big picture message from our research on the causal effect of obesity and adverse weight profiles and hospital costs is that we may have been underestimating the effect of higher BMI on the costs borne by the NHS. And as I mentioned earlier, that is the implication that we might need to spend more money treating overweight and obesity. We might need to spend more money prioritizing research into those conditions. So I think that's a very important implication. Of course, those findings are subject to the assumptions of the methods we use, but they seem to hold up across different types of estimators and different types of assumption. And I guess the next step will be to extend this kind of methodology to other health conditions. So it's generally very difficult to establish if it's a particular condition, say, heart disease that's causing people to go to hospital, or it's the fact that the people who have heart disease may be less socially advantaged than others. And again, if we can establish that there's a higher impact, for example, of disease itself, rather than the other confounding circumstances that might affect people, again, that is an implication that we should prioritize treating those people, because that will have knock-on beneficial impacts not only for those individuals and their health, but also on the NHS, and therefore potentially support an improvement across the entire population in their health and how we organize the treatment and prevention of ill health. So I'll perhaps stop there and let others comment on their research from earlier as well.
Thank you, Padraig. So in terms of the research that came from Loughborough, I think there's a couple of big messages that we got. And the first is, of course, that it was possible to establish causal effects, although it would be nice, I think, to have, we were only able to use instrumental variables from within the data set. And it would be nice to try and link those causal influences to back to the supply of health and healthcare within particular localities or for particular groups of the population, which we were not able to do. So that's something for the future research. I think the big message that came out of our research is the sort of portfolio effects. And these portfolio effects are twofold, really. The first is in terms of the movement from health towards the outcomes. And we clearly can show that changes in people's health does actually influence both their personal relationships, their social relationships, as well as their feelings about financial vulnerability. So it's important to recognise that these portfolio outcomes. And I guess part of that too, and although we didn't explore this fully in a causal setting, is that the variety of health conditions can actually drive those effects on health and mental illness that have those wider portfolio effects as outcomes. So I think for us, the future research messages are quite clear, which is to try to identify which subsets of conditions may drive particular outcomes, and also to look at the possibilities and potential for cross-agency dialogue in the first instance, but also intervention and policy change to try to move away from the focus on one specific condition and maybe one specific agency that's trying to influence that. And I think that's the message that really comes from the health as an asset project from our perspective. Okay, I'll now hand you over to Andy to offer some comments on his project.
So we know that people with health problems are more disadvantaged in the labour market, but I think what our project overall has provided more evidence on is the extent to which this is causal. For example, we know that the disability employment gap in the UK is huge, i.e. the gap between the employment rates of disabled people and non-disabled people, although that gap has been falling. And the gap is particularly high for people with mental health problems. But one of our papers has found that even though there's something like a 16 percentage point gap in the employment of people with mental health problems, actually, when you take out all the confounding and controlling influences, the actual causal effect is only about 1.4 percentage points, which is a surprising result, really, which just goes to show that investing in health is important, but it's not the full story. There's everything that goes with it: education, skills, other associated economic advantages, which actually also affect your chances in the labour market. And I think going forward, it'd be very interesting to see how the current COVID-19 pandemic is really affecting this. So, as I said before, the disability employment gap has been reducing over time, which I guess is a good thing. But could this current recession actually throw that all out the window, the progress that's been made? Are people with health conditions and disabilities actually more vulnerable to not just the health impacts of COVID-19, but the wider economic impacts? And I think that's something that we will be looking at in the future.
Thank you very much, Andy. If we could move to the next slide, please, Hardip. So the first thing I would like to do is to offer some thanks for today, and first of all to HSR UK for very bravely in some ways, but very diligently putting on the conference online. Obviously, our lives have been thrown a bit upside down by the current pandemic, so it's been great that you've been able to manage to put the conference online and give us an opportunity to present our research on our research findings. Also, as the organiser of the session, we'd like to thank very much the speakers for coming along and to outline some of the key insights for the project. And of course, last but not least, on behalf of the speakers and the research teams, to thank very much the Health Foundation for funding these projects and giving us the opportunity to apply our research interests to issues that matter to them, and also hopefully to a wider health community. Next slide, please, Hardip. So clearly, if you want to know anything about the specific project, then the Health Foundation website will give you details of those, and I'm sure that also you could look up individual speakers and contact those. But on behalf of the Health Foundation, you can clearly subscribe to their email newsletter and also register for alerts and to follow the Health Foundation on Twitter, Facebook, YouTube, and LinkedIn, and so on. And at that point, I just want to reiterate my thanks again to everybody And I hope that those who listen to this session enjoyed the session and also got something useful out of it. Thanks again.